My name is Arnie Epstein, and I'm the chairperson of the Department of Health Policy Management at the Harvard School of Public Health. In this session, I'm going to be addressing policy issues related to quality of care. Quality of care is really important in the United States and, in fact, all across the globe. But in the U.S., it's particularly salient. We spend a lot of money on quality, and there's evidence that I'll get to later in this presentation that what we're getting is not quite as good as it should be. But let me start out with something more basic. What is quality? How do we define it? The most widely accepted definition came from the Institute of Medicine more than 20 years ago. The degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Now that may sound pretty straightforward, but there's a lot of nuance there. Let me uncover some of it for you. It says the degree, making it clear that quality is graded. It's not a binary, it's not good quality versus nothing, but there's a spectrum of quality. It talks about health services in relationship to desired health outcomes, and that relationship is critical because only health services that improve outcomes are considered high quality, and only desired health outcomes that have antecedent health services causing them are considered high quality. It talks about care for individuals and populations, care for people in the doctor's office, individuals, and populations like all of us together who may not feel like we're patients at the time, but who nonetheless receive high quality if we get screened for an important disease or get vaccinated. We seek quality of care there too. The definition talks about the increased likelihood of desired health outcomes. It's not deterministic, it's probabilistic. So someone could have exactly the right health services, really high quality health services, and still have a poor outcome. And it talks about being consistent with current professional knowledge, because we can really only hold people accountable for quality of care with the knowledge they have available. On the other hand, it's a reminder to providers that they need to stay abreast, that knowledge is changing all the time, and that's important. Well, if we can define quality, how do we measure it? Here we're indebted to a scholar who was based at the University of Michigan 30 years ago, Avitas Donabedian, who taught us about three cardinal ways to think about quality: structure, process, and outcome. For Donabedian, structure were aspects of the healthcare delivery system or characteristics of a provider that might improve quality of care in terms of process and outcome. An example might be, did the hospital have the latest and greatest technology? Did the hospital have a high number of nurses for the number of patients they have? Both of those characteristics might be structural characteristics that are associated with better outcomes that are considered higher quality. Two types of process seem relevant. One is technical process, for patients to get the diagnostic services or the therapies that are warranted by their condition and thought to be effective in a timely manner, applied skillfully and safely, and that's technical process. We also worry about interpersonal process. Was the communication with the provider humane, culturally sensitive? Did it honor patient preferences? And finally, we think of outcomes, morbidity, mortality, where there's antecedent health services that are responsible. Let's try and bring this home and think for a moment together about what sorts of structural, process, and outcome measures we might use if we wanted to measure quality of care for diabetes. Take a few moments, think through what you would use, structure, process, and outcome, and maybe jot down a note or two for yourself. For structure, you might think of something like a glucose meter that would enable a patient to follow his or her own blood sugar and make sure they were dieting correctly. Or it might be something like the number of endocrinologists in a region. For process, we could think of one example of process being, did the doctor measure the hemoglobin A1C? Where hemoglobin A1C is a measure of long-term glucose control. Or did the doctor effectively educate the patient about the warning signs with diabetes, appropriate dieting, how to do his or her own testing? For outcomes, we could think again of levels of hemoglobin A1C, where a lower level is higher quality of care. Or we could think of amputations, with the idea being that if blood sugar was really well controlled, patients would have less vascular disease and fewer amputations. Well, that's how we think about defining quality and measuring quality. What do we worry about in quality? I want to indicate three particular areas that I think people are concerned about. One is overuse. Was there care the patient got that they really didn't need? It wasn't going to help them, and it may have actually caused unnecessary morbidity or mortality. Was there underuse? Did the patient get all the care they needed when they needed it, as indicated for their medical condition? And finally, misuse. Were there shortcomings in technical or interpersonal aspects of care? Were there deleterious drug interactions that could have been avoided? Were there surgical mishaps? Was there a failure to follow up on abnormal lab results? Those are the kinds of things we think about, but what's important here to take away is the three ways of thinking: overuse, underuse, and misuse. Well, if that's how we define quality and measure it and think about the problems, how good is quality in the United States? There have been many studies of this important issue. One of the most important, this was done by Beth McGlynn and her colleagues at Rand. They followed some 5,000 patients in 12 areas of the country, collected detailed chart data and surveys from them. And what they found was striking. A little more than half the time, 55% in their study, patients got the quality indicators or the health services that were warranted for their condition. The rest of the time, they didn't. There's also been a big review of this area by the Institute of Medicine. This was done some time ago, but their conclusion is probably just as true today. There is abundant evidence that serious and extensive quality problems exist throughout American medicine. Here's some of the evidence from their report that they used to bolster their claim. Roughly a third of the elderly receive a pneumococcal vaccine when they should. Roughly half of the hypertensives have their blood pressure controlled adequately. Failure to provide proven therapy for acute myocardial infarction results in 18,000 preventable deaths annually. Now let's take a moment just to think about what we mean when we cite figures like this. This is a very, very specific form of quality of care. It's not, for example, the quality we think of when we see a gray-haired clinician, long white coat, followed by a coterie of students and house staff, making rounds in one of our nation's teaching hospitals to try and diagnose someone with a complex illness. That's not what this is about. This is not about one of the brilliant biomedical scientists in our country working to ferret the secrets of the genome. That's not what this is about. This is about straightforward, algorithmic service delivery. If you have an elderly person, they should get a pneumococcal vaccine. If you have someone who's hypertensive, they ought to get their blood pressure controlled to be below 140/90. It may seem dull. It's certainly straightforward. It's algorithmic. It's enormously important. It's 98% or some large percentage of what we do in healthcare, and we don't do it as well as we could. Let me close by saying a word about how we compare to other countries. Always a source of interest. This graph displays per capita healthcare spending adjusted for the cost of living, and the orange line on top is the United States. The yellow line in the middle is the OECD average, and the others are other developed countries just as examples. And what you can see is we far outpace the world in our spending. Back around 1980, we still spent more, but we were with the pack. We're no longer with the pack. What do we get for our money? Well, it's very variable. Let me show you three quick examples. Here's 5-year survival rate for patients with breast cancer. The United States is on the far right, and we are doing better than all the other developed countries that were studied here. Nearly 90% 5-year survival. And right next to us, the United Kingdom, down close to 80%. Good news. Here's a slide showing 30-day mortality after acute myocardial infarction, and the United States is much closer to the middle. Not the worst, not the best. And finally, here's a slide showing a bit of data put together by the Commonwealth Fund. They call it mortality amenable to health care. It's their own measure. And there's the United States on the right, again, with the highest mortality rates. So the takeaway here is, depending on what the measure is, we can be leading the pack, trailing the pack, or in the middle. So to summarize, quality is really very, very important to all of us these days. We know how to define it. I think we know how to measure it. We know some of the places or areas to look for getting less than optimal quality. If we think about quality in the United States, it's clear from the studies that have been done that it's not as good as it could be. And though we spend more than other countries, there's a question about whether we're getting more in terms of our quality of care.